IBS is bad. It impacts people incredibly. It creates stress around things that should be joyful, like weddings or dates or dinner with friends. What we used to do was just kind of pat people on the hand and say, don't worry, go home and just live with it.
You could actually describe and come up with ways to help people with IBS, not just live with it, but thrive with it. Hi, and welcome everybody to the PAI podcast. My name is Dr. Asha, and I'm your host. Today, I'm super excited to have a wonderful friend of mine. This is Dr. Shannon Scholl. She's a UNC-trained gastroenterologist and a self-described microbiome nerd, which is a woman after my own heart. I love it. She's been practicing for 17 years with a special interest in treating women with IBS. So with that, I'm going to have her bio in the show notes with a little bit more information, but I wanted to welcome you, Dr. Scholl, for being here. And one fun fact that I wanted to share, because I always share a fun fact, is that she has chickens in her backyard.
That's right.
So really excited to have you on. Thank you for being here.
Thank you. I'm so happy to be here. Yeah, I've had chickens for about 15 years.
Wow.
They're fun. People don't know they're descended from dinosaurs. And you can kind of see it when you watch them.
When you watch them, I'm sure you probably have a lot of fun facts about that too. So that could be a whole other episode.
You're good.
So again, welcome. And I wanted to start with a phrase that I heard you mention when we met up, which I absolutely fell in love with, but it's IBS is BS.
That's right.
And so I'd love for you to dig into that for us and share with us what that means to you, how you came to that conclusion, and maybe even get into how people can get away from that phrase.
Sure. Yeah, I would love to. That has become my mantra, actually, IBS is BS, because, I trained at UNC I've been out about 15 years, so practicing maybe 17, and I trained with Doug Drossman, who's the father of IBS. And at that time, or one of the fathers and the thought leaders of IBS. And at that time, we didn't really understand why people had IBS. We just knew that they had it, that there were lots of different parts to it. We didn't talk about diet at all, but we did talk about stress and anxiety as a part of it. And we basically, our attitude or our approach was just to rule out diseases that we knew about. And then if you didn't have any of those, we'd say, well, good news, you don't have anything bad. But IBS is bad. It's really bad. It impacts people incredibly. It creates stress around things that should be joyful, like weddings or dates or dinner with friends, nights out, and it's embarrassing for people. It causes anxiety. The unpredictability of the symptoms cause anxiety. It leads to eating disorders. I mean, I could go on and on and on the way that IBS impacts people. But what we used to do was just kind of pat people on the hand and say, don't worry, go home and just live with it. But things have progressed since then. And there's definitely an anxiety component that can fire up the GI system and result in IBS symptoms. But IBS as a label really just says that you have diarrhea or you have constipation. And there's actually a list. I can sit down with someone and go through that list. And with a good history, I can eliminate most of them and get us on a path to testing the remaining things. And once we've got that diagnosed, then we can talk about how we're going to treat it.
I love that. So just to kind of backtrack just for a second. So IBS stands for irritable bowel syndrome. Right. And I probably should have said that at the beginning, but I love your phrase so much. So I love everything that you said, that, people got clumped into this not urgent kind of description of GI symptoms.
And they were dismissed.
Dismissed. That's exactly what I was getting at. So I'm so glad you said it that way. People feel dismissed in healthcare, which is why we're sitting here talking about this today and not feeling heard. And so I love what you said about having this list that if you had some time to go through, you could actually describe and come up with ways to help people with IBS, not just live with it, but thrive with it almost. Is how do we decide how to make things better for that patient? So I'm going to transition just a little bit because I want to talk about your practice. So I've met a lot of gastroenterologists in my day, and you are the first one that I've ever met that has actually gone into more of a non-traditional route. So can you describe that for us? Describe, what you were seeing in the traditional healthcare world, and then why you made this transition.
Yeah, I'd be happy to. So I was with a big practice for about 14 years, and I was very successful. I had a huge patient cohort. I was booked out 8 to 12 weeks. I was working, 10-hour days. And I was seeing patients over, every 15 minutes, a new patient, every 15 or 30 minutes. And I got to the point where I felt really burned out, and not just stress-wise, but I felt burned out morally, in my soul, because I really felt like I would walk into a room and I didn't have a good handle on what was going on with this patient. And I would have to review the chart really quickly and come up with a plan. And it was all just way too rushed. I wasn't doing as good a job as I knew I could do. And COVID hit, and we all kind of reassessed. And I left my practice 2 years ago, just super burned out and not sure what I was going to do. My daughter was really, really sick at that time and was in the hospital. And I talked to a friend, and she said, "Have you ever thought about doing things differently?" And I said, "What do you mean?" And she said, "Outside of insurance." And I said, "Every day of my professional life, I have fantasized about not having to deal with insurance." And she said, "Well, there's a model for that. It's called direct primary care. And the idea is kind of like GoodRx, where you just cut out the insurance middleman and you deliver care directly to the patient." And the really nice thing about that, there are so many nice things, actually. I won't even try to limit it. But from the doctor's perspective, you can make your own rules and you don't have to ask permission to do what you know is the right thing to do for the patient. From the doctor and the patient's perspective, we are in a relationship. You come in to see me and I know who you are. I have you in my cell phone as you. And when you call me or text me, I pick it up and say, "Hi, Asha, how's it going?" Mm-hmm. And we get plenty of time to talk about things. So you get to tell me your whole entire story, and I get to ask all the questions I want to narrow things, to understand what's really going on. And then as a business model, it's because we don't have to deal with insurance companies. At my old practice, we had 5 staff people for every 1 doctor. And that was so expensive. You can imagine. Now it's just me and my nurse. So it's a very low overhead proposition. And we can pass those savings on to patients. And I'll tell you the really interesting thing about this model, and it's not the most important thing, but it is just something I find so interesting, is that when you cut out the insurance and all of that bloat that they bring into it, the prices go down so much. Yeah. So for instance, if I want to send a patient to get their thyroid checked and they use their Blue Cross or United, it costs $33 at LabCorp. But going through me, and I don't make any money off of this, but because I think it's great, and I just pass my savings along to patients, but it costs $3.
Wow.
And that difference, that 90% difference, is all the costs that insurance injects into the equation. So I just find that insurance gets in the way of me caring for my patient and for the affordability of healthcare. You have to educate patients about it, but once they start doing healthcare this way, the way it's really meant to be and the way it maybe used to be back in the 80s, more affordable, more time, more relationship driven, they're on board. They love it. Patients love it. Doctors do too.
What I'm hearing is it's all about the patient care, right? Yeah. And so, which we have in the traditional model, I feel like, and most, I think, traditional healthcare practitioners would agree, is that we've moved away from that so drastically. Okay. And, in traditional pharmacy, when I was there, it was all about, I felt like I was feeding people's illnesses rather than actually helping them get well or stay well, right?
Yep. Go ahead. I felt like I was testing them until I could see them again and then do another rush job, every 6 weeks. I mean, it was just a constant game of whack-a-mole.
That's a good way to put it. Whack-a-mole. Yeah. I mean, it's just, you're just hitting one thing after the other instead of, and it was again, Band-Aid relief almost, and chasing symptoms versus actually helping them feel well. And I really applaud you for doing what you're doing, because it's difficult. It's difficult to break away from really what what you were kind of bred to do, because through school, that is what you're taught. And so really amazing to see this. And I know even early on in my health journey, I had a lot of gut issues, and it was really difficult to find the right answers in the traditional model. And not that I ever dismiss anybody that's in that model, because I think it's really important to say that it has to be there.
Yep.
And they're doing the best that they can with what they have. And so I do love what you're doing, and I appreciate that. So what are the best ways for somebody to get in touch with you? What do you offer for patients that want to come and be a part of this direct primary care model that you have?
Sure. Yeah. Well, mine's direct specialty care. I use the example of direct primary care, but I should have clarified that. But they can go to my website, which is gastrodirectnc.com. Okay. And they can either enroll directly in the practice from that website, or they can send me a message through the contact page, and we'll get in touch with them if they have questions. I answer questions about the model all day, every day, and I don't mind doing that at all.
That's fantastic. And I do know you have a really fantastic program that you have for women dealing with IBS. Is that correct?
That's right. So in my clinic, one of the things I love about this different model is that I get to talk about diet and nutrition all day. And it has always boggled my mind that as gastroenterologists, we don't get trained in diet and nutrition. We kind of leave that for the nutritionists. But it's really important. If I'm talking to you about what's going on in the middle, I have to know what you're putting in the top. And so every day in my clinic, I talk about diet, and some people want to hear about it and some people don't. And for those who do want to hear about it, I offer a 12-week online course. It's led by me. It's live, led by me. And it offers kind of a jump start or a quick start for people who really want a transformative experience and want to get in there and get going, make some changes. And you can you can heal the gut, and you can vastly improve IBS symptoms. People can regain control over their life. That's kind of the point of the course, is to empower people and fix their gut.
Love that. Empowerment is the whole, I feel like the whole piece to patient care is giving them the information that they need to be able to transform their lives, make those lasting, sustainable lifestyle changes. That's the important part. So I love that you offer that. We can talk all day. I know we have, in fact, done that before. So I would love to have you back on and talk more specifically next time, hopefully about the microbiome, because I know that's being a microbiome nerd, I want to dive into that with you.
I would love to.
But for this, thank you for sharing how people can get in contact with you. I like to end each episode with just one thing that if you're a patient listening on the other side of this, that they can take away from this. What is the one thing that you want to share?
I'd love to share two.
Perfect.
Okay. So the first one would be start a fiber supplement. And a lot of people with IBS are worried that fiber is going to make them worse, because if they eat lettuce or Brussels sprouts or things like that, they know their tummy doesn't like it. I promise you, a teaspoon of benefiber or psyllium husk will do wonders for IBS. So that's the first thing. And for all health, right? For promoting the microbiome. And the other thing is eat real food. Kind of stay away from anything that's been in a factory, and eat real food like broccoli and snap peas and strawberries and blueberries and bread, but stay away from I love Michael Pollan's quote. He says, if it's a plant, eat it. If it was made in a plant, don't.
Love that. Love that. And I will do a little plug for you. Your Instagram page is amazing. And you do talk about a lot of whole foods and things that you buy at the farmer's market and things like that. So I will put her handle in the show notes. So anybody that wants to follow her, please do.
Thank you.
Thank you again so much, Dr. Scholl, for being here. And I look forward to having you back on the podcast soon.
My pleasure. Thank you, Asha.